All right, diving in today, folks, we're tackling fingertip injuries, really zeroing in on what's crucial for the FRCS plastic surgery exam.
You bet. We've got a ton to unpack, but our mission is to distill it down, extract those core nuggets of knowledge you need to manage these injuries effectively.
And these are like the bread and butter of hand surgery.
Absolutely. You see them all the time. So nailing the anatomy, the evaluation, the treatment algorithm, it's all absolutely fundamental for the exam. No way around it.
No shortcuts here.
Nope. Let's jump right in.
Perfect. So anatomy first. Let's get specific. Where do we even define the fingertip? Where does it begin? Where does it end?
Okay, so anatomically, the boundary is distal to where the flexor digitorum profundus and the extensor tendons insert. Basically, imagine the very end of your finger, beyond where those main tendons attach. That's your functional endpoint. That's your fingertip.
So we're not just talking skin and bone here.
Definitely not. You've got the nail complex,
Hmm.
also called the perinucleum, and that's what makes up the back of the fingertip, the dorsal aspect.
Yeah.
And it's composed of, well, the obvious, the nail plate itself, then the nail bed underneath. Distally, you have the hyponychium, proximally the eponychium, and laterally the perinychium.
Right, so it's a whole little system.
Exactly. And here's a point worth remembering for the exam. The nail complex actually starts a tiny bit distal to the extensor tendon insertion, about 1.2 millimeters.
Interesting. And what about the skin itself on the fingertip? It feels like specialized.
You're right, it is specialized. It's what we call glabrous skin, meaning it's hairless.
Makes sense.
And it's got a thick epidermis with those deep papillary ridges. Those ridges, that's what forms your fingerprints.
Right.
And they're essential for that fine tactile sensation we need in our fingertips.
Okay, makes sense. And then there's the pulp, that fleshy pad at the very end. What's going on in there?
So the pulp, that's fiber fatty tissue, lots of blood vessels running through it.
Hmm.
And it's all held together, stabilized by these fibrous septa that connect the dermis to the periosteum of the bone underneath. And for good measure, you've got Cleland's and Grayson's ligaments on the sides, providing even more stability. Now, it's helpful to differentiate between the distal pulp, the very tip, which has this multi-pyramidal structure, and the proximal pulp, which is made up of two kind of spherical layers. Oh, and one more thing. For the exam, remember that the volar pulp, that's the part on the palm side, makes up over half the fingertip volume.
Wow, over half. So I guess that really highlights how important it is for function.
For sure, the pulp is key for so many things.
And then, of course, there's sensation, super crucial in the fingertips. So tell us about the nerve supply.
All right, so it's the digital nerves that provide sensation, and they originate from the C6, C7, and C8 nerve roots, coming from the median and ulnar nerves.
Okay.
They run deep in the palm, but then become superficial as they get more distal. And right around the MCP joints, they become what we call proper digital nerves, running right alongside the arteries. Then, just past the DIP joint, each of these nerves branches out, trifurcates, sending one branch to the nail bed, one to the very tip of the finger, and one to the volar pulp.
Okay, and then the arteries, what about the blood supply? How does that all work?
The proper digital artery basically follows the same pattern as the nerve, trifurcating distally and forming these two anastomotic arches.
Arches.
Yeah, one arch is right at the level of the lunula, the base of the nail, and the other one is at the free edge, the part you trim. And branches go off laterally and dorsally. One of them supplies the nail fold, and another one, well, it branches out mid-nail and then extends all the way into the volar pulp.
So knowing these arches, I imagine that's important when you're planning flaps.
Absolutely, it all comes down to blood supply.
Makes sense. And what about venous drainage? How's that handled?
Okay, so most of it's through these dominant dorsal veins, and there's a venous arch around the lateral nail wall and the distal pulp that drains proximally.
Okay.
Then you've got these midline longitudinal veins that drain into a middle venous arch. And importantly, even this far out on the fingertip, these veins have valves.
Interesting. All right, so we've got the anatomy down. Now let's say a patient walks in with a fingertip injury. What are the key pieces of information we need to get from the history?
The history, it's so important, gives you so much context. First off, age, because that really impacts your treatment options. Kids heal differently. Elderly patients have more limitations.
Right.
Then gender aesthetics can be more of a concern for women. And you got to know which hand is dominant because we might be more aggressive with treatment if it's their dominant hand.
Okay.
Then occupation is huge. I mean, a manual laborer needs a different kind of outcome than a pianist, right?
For sure.
So you got to ask about their work. And then the mechanism of injury, of course, how it happened. Smoking status is a big one. Smoking really increases the risk of flap failure. Right.
And then any other medical problems they have, comorbidities, RA, Dupuytren's, diabetes, all those things can affect flap choices and healing.
So much to think about. And then on physical exam, what are the big things we're looking for?
Always start with a full hand exam. Make sure there's nothing else going on.
Good point.
Then, zero in on that injured digit. Always check how the flexor and extensor tendons are working. You might think it's an isolated fingertip injury, but you could have a mallet finger lurking in there too.
Okay.
Then, you measure the defect precisely in square centimeters. After you've done a digital block and a good, thorough irrigation, which are essential steps, by the way, you need to figure out what tissue is missing or damaged beyond repair. Is it the nail plate, the bed, the skin, the pulp, bone? Any exposed bone, got to note that down.
Right.
And this is crucial. Define the geometry of the injury. Is it volar oblique, with or without bone exposed? Is it transverse, or is it dorsal oblique?
Because that geometry, that's really what guides our treatment plan.
Exactly.
And x-rays, are they a must-do for every fingertip injury? Every single one. You need AP and lateral views, always. And if there's an amputated part, you x-ray that too.
All right, so we've evaluated the injury. Now let's talk treatment planning, especially in the context of the FRCS exam. What are the big principles to consider?
The most important thing is you're making decisions with the patient. It's shared decision making.
Right.
You're discussing whether to go for reconstruction or revision amputation. And that discussion has to be tailored to each individual, the specific finger that's injured, and all the characteristics of the injury.
Okay.
Now, the big factors that guide your decision are the size of the defect, whether there's exposed bone, and, like we said, the geometry of the injury.
And what are the goals of fingertip reconstruction that we're aiming for?
Ideally, we want a fingertip that's pain-free, durable, and has good feeling.
Makes sense.
So to break that down, we want durable coverage of the wound. We want to preserve as much length as possible. We want near normal sensation to return. We want to minimize pain and prevent neuromas. And we want to do all that with minimal problems at the donor site. We want to make sure the joint keeps moving well, and we want it to look decent cosmetically. But honestly, the #1 priority, above all else, is painless, durable skin with good sensation.
That's the foundation. All right, now let's talk about the reconstructive options. Thinking about that reconstructive ladder, especially in the context of FRCS scenarios.
All right, so you've got your ladder. It goes from the simplest to the most complex. You start with secondary intention, then you've got skin grafts, composite grafts, homodigital flaps. That's when you take tissue from the same finger.
Right.
And heterodigital flaps, that's from other fingers. Then you have regional flaps, and finally microsurgery, the most complex. And for the FRCS, you need to be comfortable with each rung of that ladder. Know the key considerations.
Gotcha. So let's start with skin grafts. When does it make sense to use them for fingertip injuries? What should an exam candidate be thinking about?
Okay, so with split thickness skin grafts, STSGs, you generally see lower patient satisfaction because they tend to have more complications. You can get graft failure, numbness, cold sensitivity.
Right.
And they don't hold up as well as secondary intention. Now, full thickness grafts, FTSGs, they're a bit better. They're tougher. They don't contract as much. And the sensation tends to be better than with an STSG, so they can be an option for defects bigger than a centimeter squared.
Okay.
And a good donor site for those is the Venor eminence. The color match is good, there's no hair, and if the graft is small enough, you can close the donor site directly. But honestly, skin grafts on fingertips, they often don't give you ideal results, so really think it through before you choose that option.
So moving up the ladder to flaps, let's talk about homodigital flaps first. What are the big advantages that an exam candidate should highlight in their answer?
The big thing with homodigital flaps is you have the potential for near normal sensation right away, right from the start.
That's a big deal.
Huge. And that's because you're using tissue from the same finger, so it's already got its nerve supply.
Yeah.
Plus, your donor site is outside of the area that's injured.
Smart.
The trade-off, though, is that you often need to shorten the bone a little bit to get a nice tension-free closure.
Okay, good to know. Now, let's go through some specific homodigital flaps. The volar VY advancement flap, the Addusoy flap, it comes up a lot. What are the exam relevant points for that one?
Okay, so the Addusoy flap, it's good for dorsal oblique injuries and some transverse ones. You use the volar tissue that's right next to the defect and advance it distally.
Right.
Usually you get about 1 centimeter of advancement. But if you extend the base of the flap proximally, you can get a bit more. And sometimes you can even include the neurovascular bundles in the flap.
Oh, I see.
But super important point. It's not an option for volar oblique injuries.
Contraindicated.
Exactly. And for the exam, you should know that the outcomes with this flap Well, they've been kind of mixed in the literature. Adesoy himself reported good results, but other studies have shown higher rates of complications, things like cold intolerance, problems with
So
sensation.
it's not a slam dunk.
Not always. Now, what about Furlow's modified volar VY? Have you heard of that one? It's nicknamed the cup flap.
I have heard of that one, yeah.
So that one is specifically designed for volar oblique injuries.
Okay.
The way it's designed, it crosses both the DIP and PIP creases on the volar side. You lift up the tissue with the neurovascular bundles, and then you advance it distally and kind of cup it over the defect.
Oh, I see, like a little cup.
Exactly. Now, one thing to keep in mind for the exam with this flap, you might end up with some scarring on the fingertip and on the volo side.
Okay, good to know.
Yeah.
What about the volar advancement flap, the Moberg flap? That one seems to be a favorite, especially for thumb injuries.
Yeah, the Moberg, it's primarily for the thumb, and that's because of the unique blood supply the thumb has. So you make your incisions mid-axially on the back of the thumb, dorsal to the neurovascular bundles.
Right.
That way you can include those bundles in the flap, and you lift the flap up just underneath the tendon sheath. Now, the standard Moberg, you're only going to get about a centimeter of advancement.
Okay.
But there are modifications. You can make a transverse incision at the base. That'll give you 1.5 centimeters. Or you can do Dellen's web space extension. That can get you up to 3 centimeters.
No, that's a lot more.
Yeah, but it's a bit more complex too. And the key takeaway here is the Moberg is really mostly for the thumb because of its blood supply, both on the volar side and the dorsal side. It's very robust.
That's good to know. Are there any other homodigital flaps that exam candidates should be familiar with?
Yeah, there are a couple more. For transverse amputations, there's the bilateral triangular VY flap, the Cutler flap.
Okay.
That one might be the dominant option for lateral oblique injuries. It involves creating these triangular flaps from the sides of the fingertip and advancing them distally.
I see.
Then there's the oblique triangular neurovascular island flap. That's a mouthful.
It is.
That one's good for volar oblique injuries up to 2 centimeters. You basically dissect the neurovascular pedicle proximally into the web space to get more reach.
Okay, so those are some good ones to know.
Yeah. And just for good measure, you can briefly mention some other options like Houston's flap, Sukate's flap, step advancement flaps, reverse digital artery flaps.
Right, just to show you're aware of them.
Exactly, even if you don't describe them in detail. All right, so now let's move on to heterodigital flaps, taking tissue from a different finger. What's the main trade-off there compared to homodigital flaps?
Okay, good question.
So with heterodigital flaps, you can cover bigger defects. That's a plus.
Right.
But the downside is you're now operating on a finger that was perfectly normal. And the other big thing to remember, and you should definitely highlight this in the exam, is that the sensation you get with a heterodigital flap is usually not as good as with a homodigital flap. And a lot of times the patient needs what we call cortical relearning to regain some of that feeling.
So their brain has to kind of remap the area.
Exactly. A good example is the cross finger flap. You might get protective sensation back, meaning they can feel if something's hot or sharp, but that fine tactile discrimination, the ability to really feel textures and shapes, that often doesn't come back fully.
Okay, so cross-finger flap, that's a pretty common one.
Yeah.
When do you use it, and what are the complications to watch out for, especially in an exam setting?
The cross-finger flap, it's a workhorse, especially for large volar oblique injuries. You raise a flap from the back of the adjacent finger, the middle phalanx, just above the periton, and you bring it over to the injured finger, which you've got flexed, and sew it in. Then you divide the pedicle after about 8 to 10 days. Now, for complications, you want to mention the poor sensation we talked about, the potential for cold intolerance and sensitivity in the donor finger, and the fact that you're going to have a scar on the back of the hand, which can be noticeable.
Okay, good points. What about heterodigital neurovascular pedicled flaps? When do those come in handy, and what's a key thing to remember about them?
So those are more for defects on the ulnar side of the thumb pulp.
Okay.
They provide really stable coverage for larger injuries, but you'll need to do a skin graft on the donor site. And the big thing for the exam, the thing to really remember is cortical relearning with these flaps, it's not a guarantee.
So it's not always successful.
Right. You only get success about 40% of the time. So it's a bit unpredictable. And the way you do it is you dissect the proper digital artery and nerve on the middle or ring finger pretty far, approximately.
Okay, so it's a more complex dissection.
It is. Let's talk about the first dorsal metacarpal artery flap. The FDMA flap. How's that relevant for the FRCS?
Right.
The FDMA flap, it's really useful for injuries on the palm side of the thumb, the volar side. It's a pedicled flap based on the FDMA, and you take the tissue from the back of the index finger, the proximal phalanx.
Okay.
A big advantage of this flap is that it includes a branch of the superficial radial nerve, so you get some protective sensation.
That's great.
Yeah, but like other neurovascular pedicled flaps, you might need cortical relearning, and you'll need a skin graft on the donor site.
Gotcha. And what about the FDMA perforator flap, the quaba flap?
That one, it's super versatile. You can use it on the back of the hand, the dorsum, all the way up to the PIP joint. And you can use it on the palm, distally, and in the web spaces.
Okay.
And if you do it as a reverse flap, you can even get it past the PIP joint. It's based on perforators from the dorsal communicating branch of the common digital artery, mostly distal to the junctura tendinum. And the blood flow can be antegrade from the DMA or retrograde from the digital arteries.
So it's got options. Now let's talk about regional flaps,
Yeah.
like the Finnar flap. When would you think about using that one, and what are the contraindications that an FRCS candidate absolutely needs to know?
So the thenar flap, it's for those big volar oblique injuries on the index or middle finger. You use skin and subcutaneous tissue from the thenar eminence, the fleshy part at the base of your thumb.
Right.
You have to keep the injured finger bent, flexed, while the flap is healing, and you divide it after 10 to 14 days.
Okay.
Now, contraindications, big ones for the exam over 40 years old. You want to be careful because of the risk of joint contractures.
Gotcha.
And any condition that makes it hard to keep the finger bent for a while, things like RA or Dupuytren's, those are contraindications too.
All right, we've covered a ton of options. Now let's switch gears and talk about that algorithmic approach to treatment, matching the treatment to the type of injury. That's really crucial for formulating good exam answers.
It is, totally agree. You have to tailor your treatment to the size of the injury, the geometry, and of course to the individual patient and the specific finger that's injured.
Makes sense. So let's start with soft tissue loss without exposed bone. What's the go-to treatment there, and what are the alternatives that an exam candidate should be aware of?
All right, if you have an injury that's less than 1.5 centimeters squared and there's no bone sticking out, secondary intention healing is often the best way to go. You get excellent results with that.
Okay.
And for the exam, be ready to describe the procedure. Local block, good irrigation, clean everything up, debridement, get good hemostasis.
Basics.
Exactly. And there are different dressings you can use. Non-adherent gauze that needs frequent changes. It's good for contaminated wounds. You've got semi-occlusive dressings. Those can be changed less often. The patient doesn't have to be involved as much. And then there are biologic dressings like the Hyphakin cap. Those you can just leave on until the wound is healed.
So lots of options.
Yeah. And remember, healing takes time. It's usually about 3 to 4 weeks, but it can be longer for bigger wounds. And once it's healed up, you want to start desensitization therapy and occupational therapy.
Okay.
Now, if secondary intention isn't feasible, you can consider a skin graft. But just highlight that the results aren't always great. You can get cold intolerance, tenderness, all sorts of things.
So it's not ideal.
Not really. Okay, now, what about those situations where you do have soft tissue loss and exposed bone? What's the first step you might need to take?
Right, so now things are getting more complicated.
Yeah, a little bit. So if the wound is small and there's just a little bit of bone exposed, you can consider shortening the bone. Just take a little bit off the distal phalanx.
I see.
And one thing to remember, really important, when you shorten the bone, you also have to shorten the nail bed.
Oh, why is that?
You have to take about 2 millimeters off the nail bed, proximal to where you cut the bone. Otherwise, you can get what we call a hook nail, where the nail grows and kind of crooked.
Okay, that makes sense. And are there any limits to how much you can shorten the bone?
Absolutely. You never want to shorten it past where the flexor and extensor tendons insert.
Right.
That's your absolute limit. And the idea behind shortening the bone is basically to convert the injury into one without exposed bone, which then lets you do secondary intention healing.
Oh, I see. So you're simplifying the problem.
Exactly.
Hmm.
Okay, now let's get into those specific geometries we were talking about, the ones with exposed bone. Let's start with dorsal oblique injuries. How should a candidate approach those on the FRCS exam?
Okay, dorsal oblique.
With those, you want to emphasize the importance of preserving the volar pulp and that glabrous skin.
Right, the good stuff.
Exactly. And the volar VY advancement flap is often the way to go. Be prepared to walk through the key steps. You design the flap, you elevate it full thickness, you release the pulp septa, you might have to shorten the bone a tiny bit.
Right.
And then you close it up meticulously, making sure that flap is inset perfectly onto the nail bed.
Okay, sounds good. Now, what about volar oblique injuries? The nail complex is usually intact in those, right?
Usually, yeah.
So how does the specific finger that's injured affect your management? What should candidates know?
This is where you have to think about each finger individually. So the thumb sensation is king. That's your priority. So you want to go with a homodigital flap. The Moberg is a good choice.
Okay.
But if the defect is really big, you might have to consider a heterodigital option. Now, the index finger, again, sensation is paramount.
It's all about that pinch grip.
Exactly. So if it's a smaller defect, you could use Furlow's flap. If it's bigger, maybe the oblique, triangular, neurovascular island flap.
Okay.
And for larger defects, a thenar flap might actually be better than a cross-finger flap because you get better sensation.
Interesting.
Now, the Moberg flap, you can do it on the index, but the blood supply on the back of the index finger can be a little finicky, so you have to be very careful.
So maybe not for everyone.
Yeah, maybe leave that one to the more experienced surgeons. And you're generally limited to about 1.5 centimeters of advancement on the index.
All right, good to know. What about the middle finger?
The middle finger, it's all about length.
Yep.
So you might want to start with a thenar flap, just to minimize the amount of shortening you might have to do if you go with a homodigital flap.
Makes sense.
And then the ring finger and the pinky finger, those are your power grip fingers. So the most important thing is to have durable coverage, preserve length, and maintain good mobility.
Right.
Sensation is less critical there. So a homodigital flap might cost you some length and create volar scars, which could affect grip. So a cross-finger flap is often the best choice.
Good to know. Can you walk us through the cross-finger flap procedure for a ring finger injury just to make sure we hit all the key steps for the exam?
Absolutely. You start with a regional anesthetic, then you irrigate, debride the wound, get it all cleaned up.
Okay.
Then you design your flap on the middle finger, the middle phalanx, just dorsal to the peritoneum. You elevate it from radial to ulnar, taking care not to damage anything underneath. And while you're doing that, you put a full thickness skin graft on the wound on the radial side of the ring finger.
Okay.
Then you bend the ring finger and inset the flap, nice and snug. You cover the donor site with a skin graft, and then you put the whole hand in a splint, keeping that ring finger flexed.
And then you divide the flap later.
Right, usually after 8 to 10 days. And after that, it's desensitization and occupational therapy.
Perfect. Now, what about transverse amputations, where you've got loss of both volar pulp and dorsal nail complex?
So with those, you can use the same techniques we talked about for dorsal and volar oblique injuries.
Okay.
If it's a distal injury, you can consider the volar VY. But if the injury is more proximal, like through the proximal half of the scleral matrix, then shortening the bone might not be a good option.
Gotcha.
And for the other flaps, homodigital, heterodigital, regional, you just approach it the same way you would for a volar oblique injury.
So it all builds on itself.
Exactly. Now, what about those lateral oblique injuries where you've got tissue loss on either the radial or the ulnar side?
Or lateral oblique.
You can often use homodigital flaps for those.
Yeah.
And there's a neat little technique called the lateral pulp flap.
Oh, yeah, I've heard of that one.
You basically lift up the remaining volar pulp, detach it from the bone, and advance it sideways.
Okay.
Then you let the raw surface reepithelialize, just keep it moist, and it'll heal.
That's pretty cool.
Yeah.
Now, composite grafting, let's touch on that briefly for the exam. When would you think about using it?
Composite grafting is basically like a non-microsurgical replantation. You're taking the amputated fingertip and trying to reattach it.
Okay.
But we typically only do that for kids between 2 and 6 years old.
Why the age limit?
Well, the success rates just aren't that great in older kids and adults. But there are some more refined techniques out there that can be used cautiously in adults.
Gotcha.
And one thing to remember, it's generally not a good idea to do composite grafting for crush injuries. And in those really young kids, you might just opt for secondary intention healing with a biologic dressing.
So it's a judgment call. Finally, let's talk about revision amputation. What are the key situations where an FRCS candidate should recommend that?
Okay, so revision amputation, sometimes it's the best option. You have to consider it for every patient.
Yep.
Some patients just prefer it, especially if they're manual laborers and they want to get back to work quickly.
Makes sense.
Then you've got those heavily contaminated wounds or those nasty human bites. Those are often treated with a staged revision amputation.
Okay.
And then if the injury is proximal to the lunula, you'd probably do a revision amputation with nail ablation.
Right, you'd have to get rid of the nail.
And finally, if the injury is way up there, proximal to where the flexor and extensor tendons insert, then a revision amputation is usually the only option.
Okay, so those are the big ones. And what are the technical details that candidates need to remember when they're doing a revision amputation?
So you want to create a smooth, tapered shape to the bone, and you remove all the injured discal phalanx. You divide the digital nerve about a centimeter proximal to the cut, making sure it's not going to get stuck on anything.
Right.
You ligate or cauterize the digital artery in the dorsal vein to prevent hematomas. You don't advance the profundus tendon because that can cause problems with finger flexion, but you can secure it to the A4 pulley to prevent what we call a lumbrical plus deformity.
Okay, yeah, good to
And then you make sure to completely remove the nail bed, including that dorsal roof.
Gotcha. And microsurgical replantation, just a quick word on that for our FRCS folks.
So microsurgical replantation, it's more common in specialized centers, places that have the expertise and the equipment.
Right.
But you should definitely consider it and mention it as a possibility for all children, young women, and musicians.
Because the functional outcomes can be so much better.
Exactly. All right, so let's wrap up. For the exam, what are the absolute key takeaways that you want everyone to remember about managing fingertip injuries?
Okay, give us the cheat sheet.
If you have an injury without exposed bone and it's less than 1.5 centimeters squared, secondary intention healing is usually the way to go. Skin grafts, you don't use them very often for fingertip injuries. The geometry of the injury, that's what tells you what kind of reconstruction to do.
Makes sense.
Homodigital flaps, they give you the best sensation, and they're generally preferred for the thumb and index finger. Try to avoid shortening the middle fingertip if you can. Composite grafting, it's mainly for kids under 6, and you have to be cautious with it in adults.
Right.
And revision amputation, it's a valid treatment option. Don't forget to discuss it with every patient.
Perfect. All right, so for everyone out there preparing for their FRCS, make sure you've got these principles down cold.
You got it.
Review the anatomy, the evaluation process, and that algorithmic approach to treatment based on the different injury patterns. And definitely take some time to really understand the specifics of those key flap techniques.
And as you're studying, I want you to think about this. We've talked about how each finger has its own unique function in the hand, right?
Right.
So how does that knowledge, that understanding of function, influence your decision when you're faced with a fingertip injury? Do you go for reconstruction? Or is revision amputation the better choice? Think about that. For each finger, it's something to really ponder as you prepare for the exam.
That's a great point to end on. Really gets you thinking.
And hopefully it helps everyone out there crush their FRCS.
Absolutely.
Right. Thanks for tuning in, everyone.
See you next time.